Welcome everyone to our Chiari Syringomyelia Foundation Charleston support group. I'm really glad everyone came tonight. We have an awesome lecture tonight with Dr. Vanessa Hinson. And we're going to start out with a patient, Amy Mulvaney, who is going to speak about her experience with Chiari and EDS and try to focus on dystonia. So that's our subject for the night, and we're hoping that maybe she could shed some light on this is the face of a patient who suffers from this. So Amy, come on up.
Hello, as Nancy mentioned, my name is Amy Mulvaney. I want to thank you for the privilege to share my story. Actually, standing here tonight has brought me full circle. In 1989, I graduated from MUSC with a degree in physical therapy. Shortly after, I worked at this hospital, ironically on the neuro team, where I primarily treated stroke and traumatic brain injury patients. In 1992, I ruptured a disc in my low back, and after a year and a half of physical rehab for my back, I ultimately had what resulted in a successful back surgery. In 1998, I ruptured 2 discs in my sleep, requiring more surgery with 2 levels of fusion. Through much of my life, I've experienced headaches. I quite honestly thought everyone did. As the years progressed, the headaches became more frequent, more intense, and seemed to be triggered by any type of increased pressure in my head from laughing or crying hard, bending over, lifting something heavy, and extended from the back of my head to behind my eyes. I had a myriad of other symptoms as well, but also began losing my balance. Note to self, it is time to seek medical help when you are consistently running into door frames, which I decided was probably time. So in 2001, I was diagnosed with Chiari malformation with an 18 millimeter herniation of the cerebellar tonsils. Being that my career focused on physical rehabilitation, I was determined to find a conservative treatment. I sought physical therapy, neurology, and neurosurgery consults, which all said brain surgery was my only option. I underwent a posterior decompression in July of 2001. The removal of the posterior portion of my skull did not relieve the symptoms, and further tests revealed nominal CSF flow on the right side of my brain. In 2003, another brain surgery was performed to cauterize the herniated tonsils. I recalled being able to move all 4 extremities in recovery, which is an important note in just a few seconds, as well as listening to my neurosurgeon who sat beside me in the recovery room and explained that my right cerebellar tonsil was twice the size of my left, overlapping it and causing considerable pressure on my brainstem. 18 hours post-operatively, I became paralyzed in my right arm and was numb from the diaphragm down. Emergent tests revealed significant swelling where the tonsils had been, causing pressure on my brain. 3 days later, I began having difficulty breathing and experienced significant chest pain. Further tests revealed the swelling had significantly increased, and I was treated with massive doses of steroids. All anyone could do at that point was to wait and pray. While still in ICU, I began experiencing intense bolts of pain like an electric current that began at the base of my spine and went through the right side of my head, immediately followed by my right arm drawing up into a rigid spasticity, and my right leg would go into rigid extension. This bolt of pain and spasticity phenomenon came on with no warning. It lasted 5 to 45 minutes and would recur as often as 15 to 20 minutes apart. After 2 weeks in ICU and 2 weeks in a regular room, I was sent to a rehab hospital to learn to walk and write again. Although my strength began to improve, what I would later learn was called dystonia did not improve. On good days, I would have 1 to 2 bolts of pain followed by spasticity, and a difficult day would leave me reeling like a woman in the end stages of labor. When the dystonia has become the most frightening is when the muscles around my neck have gone into spasticity, restricting my airflow. At one of my post-op appointments, my neurosurgeon informed me that based on a series of markers, he believed I had Ehlers-Danlos syndrome. He referred me to a geneticist who confirmed his diagnosis. As we began to learn more about this syndrome, pieces of a medical puzzle started coming together. In 2007, I received a diagnosis totally unrelated to neurology, breast cancer. In the midst of this cancer diagnosis, I continued to experience worsening neurological symptoms. My neurosurgeon ordered an MRI, which revealed a significantly elongated brainstem for a woman my height. With this finding and the worsening symptoms, he diagnosed me with a tethered spinal cord. Only able to deal with one fire at a time, and cancer being the biggest fire, I put the tethered spinal cord diagnosis on the back burner, only to have to finally address it a few years later. Through those next 3 years, many of the tethered cord symptoms worsened. Bilateral leg weakness and numbness, significant low back pain, bowel and bladder-related issues, as well as bolts of pain through my head and dystonia that had become much more frequent and intense. In 2010, my spinal cord was surgically detethered at S1, S2, and many of my symptoms resolved pretty quickly. Unfortunately, 10 days post-op, I developed a massive blood clot that extended from my abdomen to my left knee and resulted in multiple procedures over the next 7 months. By 2014, many of the tethered spinal cord symptoms had returned to an even more significant degree. I could only walk holding on to someone or required a wheelchair. The bolts and pain and spasticity were debilitating. A second surgical detethering of my spinal cord was performed beginning at L2. After my spinal cord was detethered, my lower extremity symptoms improved significantly, but the bolts of pain and dystonia were just as frequent and intense. Further testing revealed a compression at the medullary junction of my brainstem and instability in my cervical vertebra. My head and neck often had the sensation of a bobblehead you may see on someone's dashboard. And only a hard cervical collar could offer any stability, but it did not diminish the bolts of pain and dystonia. In 2015, I was fused from my skull to C5. Since I was already fused to T1 from previous surgeries, I'm now fused 8 levels down my spine. Although it has taken some adjustment to my new normal, I'm able to walk without assistance and am making progress. I still experience occasional bolts of pain and dystonia and treating it with medication. We have learned that it seems to be that this dystonia gets worse whenever there is some sort of pull or stretch or compression in my brain and my spinal cord. Since 2015, I've continued to battle headaches, and in February of 2017, it was discovered through more tests that I had developed a blood clot in my jugular vein into my brain, increasing my CSF pressure and requiring a VP shunt. Tests revealed I have a blood clotting disorder called lupus anticoagulant that has contributed to these clotting issues, and I'm now receiving treatment. As many of you who struggle with Chiari and EDS know, it's a day-by-day journey, sometimes 2 steps forward, followed by 3 steps back. But I prefer to focus on the forward steps, as I truly believe the old adage, an attitude of gratitude, is a huge part of the healing process and living with chronic illness. Although this has been a long journey, I have my family, friends, and many doctors and nurses, and ultimately my Savior Jesus Christ to thank for helping me along this journey. I believe we are all put on this earth for a purpose. If what I've experienced has helped educate another doctor or offer another patient hope, then my life's journey will have been worth it in the end. Thank you.
What a story.
Yes.
It's hard to believe that that's your story because you have this amazingly healthy glow about you that is really hard to put together with what you've been through. So that's probably displaying a wonderful attitude. It really shows. So thanks for sharing that.
Yeah. So I have the privilege to introduce Dr. Vanessa Hinson. She is a PhD, MD, and she's professor of neurology and director of the Movement Disorders Program at MUSC. She's a mover and a shaker. She's the first woman full professor here in neurology, right?
Yeah.
She earned her medical and doctoral degrees from the University of Hamburg School of Medicine in Hamburg, Germany. After completing a research fellowship at Wake Forest University in Winston-Salem, North Carolina, she trained in neurology in Munster, Germany. She completed her residency at MUSC, where she also served as chief resident. Following fellowship training in movement disorders at Rush Presbyterian St. Luke's Medical Center in Chicago, she joined MUSC's faculty in 2003. Dr. Hinson's special interests include the diagnosis and treatment of dystonia, botulinum toxin injections, Parkinson's disease, Huntington's disease, and other movement disorders. She's a wonderful doctor, and I'm very privileged to be able to call her my boss. So it's my pleasure to introduce Dr. Hinson.
Well, thank you for inviting me. I think this is it's a really good topic to talk about because dystonia associated with various other neurologic disorders can really make or impact one's life significantly, as Amy's story indicated. So why are we talking about this? I think really because of two reasons. One, I think it's really important that we realize that dystonia can be a presenting symptom of somebody with a Chiari malformation. And so if we understand, or the general public understands more about dystonia, or doctors, practicing neurologists understand to evaluate patients for Chiari if the dystonia presents a certain way, I think we would help many patients get a diagnosis earlier. And then second, obviously, as with your case, Amy, dystonia can be a symptom of already known disease or a complication of a known disorder. But I think number one is not to underestimate, because there are so many people who for years have no clue to what their diagnosis actually is and what explains the many symptoms. So if we can recognize symptoms that are not very obviously associated with a Chiari as being due to Chiari, we would really serve the community here. So what does this word actually mean, dystonia? It is a neurological movement disorder. What defines a dystonic movement is a movement that leads to an abnormal, sustained muscle contraction. Much different from a tremor, right? Where you kind of fibrillate with your muscles, but your muscles don't assume an abnormal posture. So here with dystonia, we have a contraction of the muscle that is sustained long enough for the body part to be pulled into an abnormal position. This can be happening intermittently, as with Amy. She's talking about, at least the way I understood you to say, you're having attacks of spasms followed by periods of normalcy. Or it can be continuous. So there are patients where that abnormal sustained pull is continuously going on. Maybe there is a superimposed spasm, but essentially the abnormal position is persistent. Now, in my practice, when I evaluate patients for dystonia, the most common cause can be quite frustrating for me to explain to the patient. Essentially, I'm saying, I don't know why you have that. There's nothing that seems to trigger this. It is not genetic. It is not mediated by trauma, by Chiari, by medication. It occurs, what we say, in an idiopathic or sporadic fashion. That, by and large, is the most common scenario. And then we have patients who come to medical attention very early in life, young children with dystonia. And in those children, when we test them, we often find that they have a genetic cause for dystonia. There are certain populations or ethnic groups that are predisposed to that type of dystonia. For example, Ashkenazi Jews have a common gene mutation called DYT1 that leads to children affected with this gene to have generalized body dystonia that is permanent, sustained throughout their life, and they're born with that. So that's a genetic mutation that we can see in these children. We can see dystonia occur after a brain trauma or a spinal cord trauma, after car accidents, after a fall. We can see limb dystonia, even after a seemingly trivial fall. So the patient might have sprained their ankle, maybe was immobilized for a period of time, and coming out of that trauma situation suddenly develops a sustained muscle contraction of their foot. What we also count as traumatic, and many of you understand why we call it traumatic, if you have a prolonged dental procedure, quite traumatic to me usually, root canal or something of that nature, where your mouth is propped open for sometimes hours at a time, we sometimes can see dystonia of the jaw come on following that prolonged dental procedure. And then we see dystonia in our practice that is associated with other neurological problems. Parkinson's disease patients can have dystonia. Stroke patients can develop dystonia depending on where the localization of their stroke occurs. And Chiari patients can develop dystonia, and obviously we'll talk about that more in detail. And then lastly, I want to mention this because it is to some degree at least relevant to your group of patients. Psychogenic dystonia, what does that mean? That means it's dystonia that is triggered by very stressful life situations. And a stressful life situation can be dealing with multiple clinical disorders, being diagnosed with cancer and Ehlers-Danlos and multiple problems at once, can overwhelm the brain to an extent where dystonic symptoms can be an expression of stress. It is not uncommon. I see it quite a bit, and we treat it much differently than we do these other variants. So it's very, very important to recognize. Treating that form of dystonia the same way we treat the other forms would be wrong and would not improve the patient. So how does Chiari, and I apologize for that fuzzy picture, it wasn't fuzzy on my computer. How does Chiari cause dystonia? It can cause dystonia at a number of levels. Dystonia is produced primarily at the brain level. It is produced by a structure of the brain that's kind of located in the center of the brain where that yellow arrow shows that says hydrocephalus. But in that area of the brain, the center of the brain, we have kind of deep nuclei called the basal ganglia. And a malfunction of these basal ganglia typically causes dystonia. Now, what is important to know is that these basal ganglia don't work in isolation. They connect with other brain areas, primarily the cerebellum, and then give outflow and input into the spinal cord and from there on into the extremities. So in a Chiari situation where the cerebellum tends to be herniating or be placed lower than it should be and tends to be compressed here, the outflow of these deep nuclei can be disrupted by compression of the cerebellum. We can have dystonia from that. Many people with Chiari malformation experience hydrocephalus, an accumulation of brain fluid or CSF, and a lot of pressure at the center of their brain, and they can compress these deep nuclei and develop dystonia. And finally, another complication that we know of very well within the spinal cord is the formation of a fluid cavity called the syrinx in the center of the spinal cord. And I told you before, all this information from the brain flows down into the spinal cord, and when the signal is disrupted there, we can have dystonia. We can also have dystonia if something goes wrong during surgery and we're tickling the wrong part of the brain and are inducing signals that shouldn't have been induced. And so that would be the last scenario, essentially a sequelae either from scar tissue or minor damage to the spinal cord or brain from the actual surgical procedure. So this is not an uncommon symptom in people with Chiari malformation. Now, how can a dystonia present? What body parts can be affected? I see a lot of patients with eye dystonia. We call that blepharospasm. I'll show you a picture of that in a second. So dystonia can be focal, one body part, the eyes, the neck, the hand. It can be segmental, affecting contiguous body parts, the face and the neck and the arm, the leg and the trunk, but it tends to be connected body portions. Or it can be generalized, like I told you, with children who have a genetic form of dystonia. So here are some examples of what this looks like. The first example is that of cervical dystonia, neck dystonia, or spasmodic torticollis. If dystonia is the presenting symptom of a Chiari malformation, tends to be one of the more common ones to present. You can imagine if your neck or your cerebellum is being kind of cut off by your neck here, that your brain can tell your body to assume a different position to kind of escape that compression. So here we have a patient with a right head tilt, a left turn, right shoulder elevation. These muscles are contracted in a sustained muscle contraction. And you will be hearing from a patient like this that, interestingly, if she touches her neck in a certain position, that contraction will improve temporarily. That is actually a tip-off for us clinicians that this is dystonia. We call this a gest antagoniste, or a sensory trick. The patient touching gently their chin or the back of their head, and for some reason, the patient can trick their brain out of producing the spasm by giving this distracting stimulus. And so when I make this video play, you will see a little bit more what this looks like or feels like for the patient. She has a restricted range of motion. If I ask her to look over her right shoulder, that would be very difficult. If I ask her to tilt her left ear down to her left shoulder, that would be very difficult. Now, sometimes in these patients with cervical dystonia, we also see head tremors develop. Why is that? Kind of like this. The brain kind of realizes that she's off, that her head position is not quite right. So the brain is trying to do something nice and is trying to correct that abnormal posture by pulling. So now we have a pull induced by a corrective attempt, and then the pull of the dystonia going the other way. And what we see are very coarse head tremors, kind of back and forth. They're not regular, not like an essential tremor, the hereditary form where we have a regular bobbing in a yes-yes fashion. These pulls are usually left to right, or no-no, and quite abrupt and non-rhythmic. So that's called dystonic tremor at the neck level. If a patient comes in like this and also says, I've been having these headaches that occur when I laugh or sneeze, you want to image that brain and spinal cord and see what's going on. But again, most commonly, this occurs in isolation, not Chiari related. However, we need to be very sensitive to this being a potential symptom. Here is an example of the eye dystonia that's called blepharospasm. These patients will usually come to their eye doctor's attention first. They will complain about sensitivity to light, and triggered by bright sunlight, they will start blinking their eyes excessively to a point where some of them are unable to open their eyes and are legally blind. Legally blind by essentially spasms of their eyes that are continuous to a degree that they can't see. So very focal, usually doesn't spread from there. We call that blepharospasm. Here's an example of a limb dystonia. Oops, that's not it. This is a patient with a form of parkinsonism, but that's essentially irrelevant here. What is relevant is to look at the way that she holds her arm, and it can give us an example of what a patient experiences when their extremities are being pulled in an abnormal dystonic position. So her left hand is dystonic with sustained muscle contractions of her thumb turning in. She's also kind of flexed at the wrist. And her arm is so tight that it actually, if she doesn't hold it down, it will kind of tighten up with a spasm and kind of, you'll see it gravitate up. So she has a tendency to just kind of hold her arm down because otherwise it will kind of gravitate up the side of her body like it is now. And you can see that tightness in her arm. These muscles are like rocks. They're very hard. This is by far her worst complaint with her Parkinsonism. If she could wish one thing away, it would be the tightness of her arm. Everything else comes after that. And it essentially makes the use of her left arm non-existent, even though she has full strength if you did strength testing. But it is a similar disability as after a stroke, where you can't use your arm because it's weak. Now you can't use your arm because it's tight. In this particular person, this is not intermittent, this is continuous left arm dystonia. And here, to conclude the examples, is a young child with that genetic form of dystonia, who has a cousin who has the same disorder, and hers looks a little different. We see this sometimes in children. You can see her neck also being pulled. In her case, she's tilting to the right, turning to the left, but she's also kind of going forward. She has a lot of kind of restless movements along with that. We call that hyperkinetic compensation, but that's another attempt of the brain to kind of compensate for being pulled the whole time. And with her, she's being pulled everywhere. It's her trunk, it's her neck, it's her arms, it's her legs. And so the brain is trying to constantly shift against that. So she appears quite restless. You can see her left arm assuming these kind of spastically looking postures. And so it certainly affects her as a whole.
It looks like she really hyperextends those fingers.
She very hyperextends, yeah. So with dystonia, you can either see hyperextension or you can see flexion. It's not really predictive.
And is it very
Go
painful?
ahead. Is it
Very painful? Like
painful? So dystonia can be painful. I am very surprised that I have a number of patients whose neck posture looks extremely painful to me, who don't find it painful or don't experience pain. And they're bothered by the fact they can't turn their head left and right and therefore can't drive. So it varies a lot. These lip postures tend to be very painful.
in physical therapy, same thing. Sometimes they complain of pain, sometimes they don't.
So you see that in your practice also?
But
Yes.
Yeah, something like
Yeah. The generalized patients usually, and I don't know if the body gets so used to these postures, don't have that pain level. Most commonly I see the pain reported with the episodic, like Amy is reporting, we're getting pulled in spasms on and off. That tends to be experienced in a more painful way than the generalized, or the eye spasms aren't painful. But you wouldn't see those
Yeah, 'cause
patients.
it almost
They don't
looks
come to
like it's-
physical therapy.
Right, it looks like it's a chronic Charlie horse almost. You know what I mean?
Right.
And when you have that, it's so painful that sometimes does it hurt?
I know.
So,
Yeah.
Okay.
But it's interesting how that can vary. And the other point I wanted to bring home one more time, because I find that very fascinating, and I think it is underappreciated, is what stress can do to your body to mimic symptoms of dystonia. So this is a stress-induced dystonia, psychogenic dystonia, in a young woman who has gone through several traumatic events. She has affection of her face, pulling of her facial muscles, her neck, her left shoulder is elevated. So very similar symptoms. Her tongue is pulled up in a tight, abnormal position. She's unable to vocalize and speak clearly. This is episodic. She has episodes of complete normalcy in between. I find that extremely important to recognize and treat appropriately. The treatment is very different, as I indicated in the introduction, compared to the other forms of dystonia we've discussed. People with stress-induced dystonia do very well with special forms of psychotherapy called cognitive behavioral therapy that teaches their body to use a different outlet for managing their stress rather than physical symptoms. On a small scale, to explain why this is happening, if a speaker is nervous about giving a talk and is holding a laser pointer and is shaking, that's a stress-induced movement. This is just as much a stress-induced movement, except for obviously on a much larger scale. We have certain diagnostic criteria to identify this as being a stress reaction. It is especially hard to recognize if the patient also has other neurological organic problems, such as a Chiari or Parkinson's, and then has a stress reaction on top of that, because their exam is abnormal at their baseline, and now they're having this type of reaction. But movement disorder specialists are very well versed to recognize this and to get people into immediate psychiatric care. It can be quite disabling, almost more disabling than the organic forms. So what do we do about this? The organic forms, as we have recognized them. So there's different approaches. We'll talk about the use of medication. We'll talk about the use and utility of injections of botulinum toxin, also known as Botox and other brands, surgery, and then certain physical therapy approaches that you can chime in on, but my patients tend to like myofascial massage. Actually, starting with that, is that something you incorporate in your practice?
Mm-hmm.
Where do you practice right now?
I just opened a private practice a few months ago on Daniel Island.
On Daniel Island?
Physical Therapy and Balance Center. So I'm incorporating balance with these type of patients as well.
That's wonderful. We need to jot that down. Well, it's always good to know where clinicians practice and have experience here. So the issue is, obviously, with physical therapy, we want to work on range of motion, but we also, especially in patients who suffer from a lot of pain, want to really get to the pain fibers, which tend to be quite deep, which is why the myofascial really get to the fascia of the muscle. The muscle is wrapped, essentially, by this fascia that surrounds it, and that's where the little nerve endings that produce the pain tend to sit. So if we get to a physical therapy technique that gets deep enough to affect the nerve endings, we're really doing well with pain control. So that's just a little plug for that. But let's get to the medications that are usually prescribed first line if somebody comes to our practice with any symptom of any of these dystonias that we just looked at in these videos and pictures. There are 3 medicines that we find helpful. Why we find them helpful is because they work along those brain circuits that are directed by these deep nuclei that are causing the dystonia. We know what neurochemicals are responsible, I should say, for creating the abnormal muscle contractions. We're trying to counteract that essentially with chemistry, if you want. So the first one that we find most effective in most cases is artane. The generic is very long and wordy, trihexyphenidyl. It is a very effective medicine with the downside that many people can't tolerate it because of side effects. So essentially what I tell my patients is, let's go with this first. If you can tolerate it, this is your best bet. If you can't tolerate it, we'll go to number 2 and 3. But we want to go with what is most high yield first. This is what we call an anticholinergic, so it antagonizes the hyperactivity of this neurochemical called choline, into the acetylcholine system. We want to downregulate that. Potential side effects, dry mouth, urinary retention, just a little bit of word searching difficulty. And patients are very different with this as well. Some people can tolerate high doses. They have no side effects. And I give them a half a tablet a day and their mouth is so dry they can't speak. So very differential response, but a very effective medication, especially well tolerated, ironically, in children, where you think you would give them smaller doses because they're little people. Children can take about 10 times the amount of this medicine compared to an adult. So with high doses of this artane, we got this child that you saw with the generalized movements very well out of the wheelchair walking. That's pretty impressive. Let's suppose somebody unfortunately cannot take this or is taking it but still has residual symptoms. We then used one particular muscle relaxer called baclofen. It has been shown that other muscle relaxers like Flexeril, for example, or methocarbamol cause more side effects and are less effective in people with dystonia. So that's why we're choosing this particular one. The brain in dystonia, because we know exactly where it's originating, tends to be quite sensitive to side effects of the other muscle relaxers. It tends to make people kind of loopy and sleepy and not exactly what you want to be like when you want to function throughout the day. So the baclofen seems to be better tolerated. And then our next choice, which is equally good, is the clonazepam, which is in the same class, and it's a benzodiazepine as Valium. And Valium as well as clonazepam, it's a potent muscle relaxer. So knowing that, we tend to choose a Valium-like medication that tends to not make people as sleepy during the day. Most of us, if we took a Valium, would be snoozing through this lecture, but if we maybe took a half clonazepam, we could still stay awake. So the goal here is to relax these muscles without making people too sleepy. Interestingly, people with dystonia can tolerate these medicines that make people sleepy, like the clonazepam and Valium, at much higher doses compared to people who don't have dystonia. And it almost seems like the brain is kind of craving this and utilizing it productively instead of just putting it into the sleepy compartment and put you out. So I have people walk around high doses of these medicines that would certainly make me non-functional, 100% for sure. But their brain uses them up for a good purpose. So these are often used in combination and can be quite successful. Unfortunately, they don't work on an as-needed basis. So we need to take them every day and build up a certain level. Now, speaking of side effects we don't want, such as sleepiness, urinary retention, dry mouth, treating the muscle where the muscle most needs it with a local injection tends to make a lot of sense, right? So whereas you pop your Artane or your clonazepam and it goes everywhere in your body, including your sleepiness center, if we use an injectable medication and inject it into the muscle that causes the abnormal pull, we're often doing the patient a bigger favor. And so if we can isolate the muscle groups very well and say, this sternocleidomastoid is affected and the left splenia is causing the head to do this, an injection of Botox, botulinum toxin, can be actually much better than these by-mouth medications. Now, how does botulinum toxin do this? Botulinum toxin is kind of the generic name for Botox and other medicines in that group. Dysport, Myoblok, Xeomin, there's several others. What we do here is what we call a chemodenervation. We take away the messenger function from the brain that tells the muscle to contract. Because if the brain gives the muscle the signal to contract, but we're disrupting that signal, then the muscle doesn't contract and it's relaxed. So we're using that technique. It is very useful if we can isolate the muscle. In that child that has dystonia, I can't inject every muscle. That's not feasible and not good for that child to be exposed to that much botulinum toxin. But if somebody has the neck dystonia, the eye dystonia, the limb dystonia, we're using this technique a lot. Works for 3 to 4 months. You have to do it again. But you don't take a pill every day. You don't feel sleepy. You don't have urinary retention. It's a good way to treat this. And then in some people, we use the baclofen in the form of a pump, mostly for those who have an overlay with spasticity. Spasticity occurs when the spinal cord is injured, which could be from a syrinx, from the Chiari compression, or from a Chiari surgery. Spasticity is a little bit different movement than dystonia, but oftentimes they kind of go together. Like you were kind of calling yours, spastic dystonia. It's hard to tell one as well. Both are tight, both draw your arm up. But if they occur together, sometimes if the symptoms are severe, we actually use a little catheter, or Dr. Patel and his colleagues in neurosurgery, to get a pump that's implanted under the skin to pump the baclofen directly into the spinal canal to be acting more directly on the spinal cord to relax these muscles and keep them from contracting. We don't do this for focal forms of dystonia. This is really for more widespread problems, and this is after the patient we've determined that didn't respond to the by-mouth medication, that didn't respond to the injections. This would kind of be the next level. But we have a quite sizable group of people who get these pumps placed and who do very well. But it's important to mention that best suited for people who also have a degree of spasticity. That just, from observation, tends to be the group that does best with this. The good thing is that the surgeons can do a trial. before they permanently implant a pump and say, oh, let's see if this works for you or not, I'm going to do a permanent surgery, they can do a trial. They can insert the catheter, in an outpatient setting, pump some baclofen in there, and if you relax, well, good. They'll do the permanent one. If you don't, we'll rather not do that, obviously. So there can be a test dose given, which is good, and predicts the response. I also,
I'm sorry, Dr.
Go ahead.
Hinson, why wouldn't that work? Why would it not be effective
For pure dystonia? Oh, for some patients?
Right.
I think those are probably the pure dystonia patient without too much spasticity.
Okay.
If your dystonia is purely basal ganglia derived, a quote-unquote peripheral baclofen pump is probably not going to fix it. So I think it was then the wrong patient selection, essentially.
Okay.
Doctor's fault. And then some people get too relaxed with this, and it doesn't work because they get floppy, right? I mean, if you stick somebody a catheter in the spinal cord and you give them relaxation medicine, they might be very, very floppy, and that might not be a good idea, right? So the same can happen with pills, but you would have to take a good amount of pills to be really, really floppy. You can imagine if your neck's this tight, to get this thing to be floppy, that takes a lot of medicine. But with this, because it's so potent, we can see that as a dose-limiting side effect. And then in these children who have dystonia everywhere, the genetic forms, we often also do a brain surgery called deep brain stimulation, where we use a pacemaker device that we implant in the brain that essentially overrides the abnormal activity of these brain nuclei, the basal ganglia, and gives them a healthy rhythm of communicating with other brain structures. That would not be used for people with Chiari because we have a structural problem. We don't want to put a brain stimulator into that, but just to say why it was mentioned on a previous slide. So those are the treatment options, and depending on what the scenario is, we would choose one or the other. The good thing is that these, whoopsie, I'm sorry, I'm totally messing my own slideshow up, that the therapies can be quite effective and can make a big difference in the patient's lives. So, for example, with botulinum toxin treatment, with the injections that I mentioned, I give my patients a questionnaire when they leave my clinic, and I tell them the peak dose of this injection, the peak relief effect, will occur in 2 to 3 weeks. Mail me back a questionnaire that tells me how you're feeling. Are you 20% improved, 50, 80? And so a good response to me is if I get a letter back that says 80% better. But that's kind of where I set my bar. That's what I want to see. Anything below that, I think I can do better by modifying the injection or maybe adding a little bit of the by-mouth medicine. But just to show you what improvement I expect. That's what I expect. That's pretty robust. That's good for neurology. We wish we had a cure, but 80% improved, I would take that. Same thing with the pump. We do expect robust improvement. With by-mouth medication alone, in adults, I would say 50-60%, that's a really good response. In these children, we can, for some reason, achieve more sometimes. So it varies. And then I told you that the stress-induced dystonias, we sent to psychiatry, and we're having outstanding outcomes. The key here is to recognize them, not give them Botox injections or oral medication. That is wrong. And to get the patient to understand the concept that we're not blaming them for their symptoms. It is not their fault. The movements are involuntary, but they need to be treated differently. If we convey that in a sensitive manner and the patient actually goes to therapy, they're doing very, very well. So basically, in summary, we know why Chiari and associated problems such as the syrinx and hydrocephalus and the surgery can cause dystonia. But I think it is somewhat underappreciated that this can be a symptom associated with this array of disorders. So we need to understand that abnormal posturing of the muscle, either in the neck or in the limb, which is most commonly the problem with Chiari, can be a presenting symptom or a complication. And we need to understand which medicines are most useful, when should we use injections, and when might the pump be appropriate to help our patients out. That's basically all I have before you now have some time to ask me questions, if you would like to. Thank you.
you have a patient with EDS, and which typically causes the ligaments to be lax, is that something that would be contraindicated to then try to relax the muscle, which is going to be there?
Right, that's a very good question. We encounter that also in patients, for example, with multiple sclerosis. They already have weakness, but then they get spasms. So if you treat the spasm, do you make the weakness worse? What we find is that the botulinum toxin or the Botox is so titratable. We can vary these injections and adjust them in an almost very customized fashion. Right? I mean, Ellen is in the clinic with me. We can put, 0.05 milliliters difference in the muscle. So usually we can find the right dose to not over-relax. Much more problematic would be a pump, or even, to me, more problematic to regulate the pill type of medication, because everybody's metabolism is different. Your liver might work differently from mine. Your kidney, gets rid of stuff differently than somebody else's. And so because it is not as titratable, I think that would be more of a worry. With the injections, we would use probably a more conservative dose at the beginning, but I do not see it as a contraindication or something that I would say, I'm not injecting you because you had ED. But I think we need to obviously be sensitive to that, but it is very adjustable by minuscule doses. So we don't have to go from 100 to 50. We can go to 51 units, 51 and a half. So it's very small adjustments.
So along those lines, I have a 23-year-old patient with cervical dystonia with EDS. Very, all over the place, very unstable knees, hips, everything, neck. And so my mind is, how do I safely go in and work on her deep neck flexors when her dystonia is, everything's so strong on that side that I can't even get in there to do it. So I'm wondering, and she's from out of town.
So you need to pre-treat her with botulinum toxin, so then you can go in and do your job.
Okay, because it's hard for me to treat her at all, and she lives downtown, so it's going to have to be a thing where she comes in.
Right, so a patient like that, and we have the same problem. Sometimes I want to inject exactly where I can inject because the patient is
right.
But we can somehow get there. And then after the first treatment, then the next treatment is easier because we've loosened up and gained some ground.
Yeah.
So we often work with a therapist, and we schedule therapy to start about 2 weeks after injection, because that's when the injection reaches peak dose. So it takes a few days to start working, then we reach peak dose at 2 to 3 weeks, which is when we want the therapy to start, and hopefully maintain it there for 3 to 4 months.
Okay.
At which point it drops off, we go back in, re-inject, and then 2 weeks later we are at peak dose again.
Yeah, that's interesting, because she is unstable.
Right.
So
We also sometimes pre-treat for Dr. Patel and his colleagues in neurosurgery. Imagine you have a patient who has a head tremor from dystonia, and Dr. Patel would like to fuse them. They're going to pull out his hardware unless we, weaken these muscles and keep them from pulling. So we've seen patients that the neurosurgeons want us to weaken these muscles before they put in what they put in.
I think she's getting ready to see him, so she was asking me about that. So I'll have to go back and touch base with her and see.
Absolutely, but that's something we can certainly do.
Good.
Is dystonia due to Chiari treated the same way as idiopathic dystonia, or?
The worse the Chiari, the more likely the dystonia. Is that what you're asking, Chiari?
No, so basically I was asking, is it treated in the same way?
Oh, I'm sorry, I thought you meant Chiari 2 malformation as in second degree. So your question is the dystonia that is due to Chiari treated the same way?
Exactly.
The exception would be that the deep brain stimulation surgery that we use for other forms of dystonia would not be used for Chiari, but we would still use the Botox injections and the by mouth, and sometimes even the pump. Yeah, so those 3 options would still be applicable.
And would they also relieve the head tremors if they have?
Yes, so with the Botox, we're very good at relieving head tremors.
So basically both symptoms are controlled. So
Right,
if
because
dystonia responds, the head tremor responds as well.
Yes,
Okay.
because the tremor is caused by the abnormal head position, because your brain wants to correct the head position. So if your head position is normalized, the brain no longer creates the to and fro. But we will also specifically target people with head tremor, the two muscles that we know are going like this, back and forth. And because the Botox can be specifically put in there, yes.
So I have another question, and I'm still thinking through it. So if their dystonia is creating hyper, say, extension, like with the child and the
Yes.
fingers being hyperextended, and then, of course, that creates a weakness in the joints because of the stretched ligaments over time, and we needed to go to bracing once their dystonia is controlled a little more so that they can have more functional movement. But is that something?
Do we go to bracing a lot?
Would you
with
go?
dystonia?
Yeah, could you go? And I'm just putting together the EDS and the hypermobility once the dystonia is under control, but still they've got so much movement that they can't control their movement. Like with that.
And now they're damaging their joints even more because
Right.
they're having so many excessive contractions.
Right, exactly.
And then we have instability of the joint.
Right.
I think in that setting, bracing would make a lot of sense.
Right.
Yeah. We also use bracing in people with post-stroke dystonia, as you know. Post-stroke, you often have spasticity of the hand or dystonia of the hand with the hand completely fisted. So we open it up with Botox and then use splinting to kind of maintain that benefit and stretch those ligaments. In this case, we want them stretched.
Right, right.
You know.
So, yeah.
Yeah.
I'm not for a long time.
All right.
All right.
Well, hopefully we demystified this a little bit without being too scary. But the good thing is that we can make a big difference here. So thanks for having me.
Thank you.
Okay, just a couple things. We are going to have someone at our May meeting talk about intubation and different oral and maxillofacial and swallowing issues and things like that. And I understand some people were having difficulty signing up for the meeting. It really helps to register because then we know how many to prepare for. And we were looking today at the mobile version of the CSFinfo.org, and we noticed that there's a spot there where you have to download the desktop version. So you need to scroll down and then see where it says download desktop version, and then that will take you into where you can register. Okay. Our support group, I'm really happy everybody came tonight. We have some plans for the future, and one of them I'm working on is a walk, United Night Walk, and I'm hoping to do that sometime in September, probably mid to late September, looking at James Island County Park. So we'll keep you updated with how that progresses. Okay, so thank you everyone. Thank you for coming.